I am so excited to have Matt Reiter back with me today. Matt is the Vice President of Capital Associates, a bipartisan government relations firm in Virginia. Since joining Capital Associates in 2014, he's helped the firm's clients advocate on legislative and regulatory health policy issues, ranging from transition to value-based payment systems, provider reimbursement, access to care, and effort to reform the U.S. healthcare system. Matt has been on the podcast before, and we were just chatting earlier about, what we talked about in 2021 and how it compares to what we're going to talk about today in 2022. So thank you so much, Matt, for joining me. Let's get right into it. Let's start with the No Surprise Act. So give us an update about that.
Sure. Well, of course, thanks for having me back. Happy to be here and talking with you again. And yeah, when we spoke a year ago, the No Surprises Act was one of the top discussion topics. And here we are a year later, and it's still the top discussion topic because there's a lot of, now we've seen the regulations come out that dictate or explain how it's going to be implemented. So we knew from the legislative standpoint what the framework was going to be. But now CMS has issued 2 interim final rules and several FAQs and guidance documents that really explain the fine details of how it's going to be implemented. And what we're finding is that either some of those details are going to be incredibly difficult and problematic for RCM companies, or also some of the key details that they need to serve their clients are frankly missing. So it's just going to be an ongoing fight to figure out how to get this to work or to make changes to it to get it to work. And if we can, and CMS has recognized that some of the things to put into the regulations are not ready to go this year, because the No Surprises Act technically took effect January 1st of this year. So they delayed enforcement of some of those provisions, which are a little bit more challenging. So I'll just kind of give a very quick overview of kind of how I look at the No Surprises Act as 2 different pieces. I'm not going to really spend too much time explaining or summarizing it. If you're interested, HBMA has a really good guide that I wrote on the No Surprises Act. It's about 6,000 words. I believe it's also available on my firm's website, capitalassociates.com. It's really good, comprehensive, kind of next level summary beyond just kind of the 2 or 3 pages you might read somewhere else. But there's really 2 parts to the No Surprises Act. The first being the patient protections for these out-of-network services that occur in hospitals and ambulatory surgical centers and emergency departments. And just to be clear, the traditional physician office that's not part of hospital system is these patient protections don't apply to services that occur there. So these are really hospital services where the patient goes to an in-network hospital or facility and they get care from an out-of-network provider in that in-network facility, or if it's really any out-of-network emergency care that they get. And there are some key details about that. If the surprise scenario occurs, how do you figure out the payment from the health plan to the provider? So the patient is protected in that they don't need to pay more than their in-network cost-sharing amount. And then to resolve the payment dispute between the provider and the out-of-network provider and the health plan, it creates a basically mandatory negotiation period for 30 days, and then the opportunity for an arbitration process. And so there's a lot of details about that. First, I will say is the No Surprises Act statute basically listed things that the arbiter can and cannot consider in those arbitration hearings. This independent dispute resolution process, what's called formally. And it lists things like, okay, you can't, the arbiter cannot consider Medicare or Medicaid rates because those are usually well below. They can't consider the provider's, bill charge because it's, also pretty high. And one of the things that the statute says that the arbiter can consider is this qualified payment amount, which the regulations define as the median in-network rate for the plan as of January of, I think, 2019, that's indexed for inflation. And that's one, obviously that's something that they lean on throughout the No Surprises Act, but the way the statute is written, it's just one of several factors that can be considered. But the way the regulations are written is it says that in the IDR process, this QPA is the assumed correct amount unless the provider can justify otherwise. So the CMS went further than the statute, than Congress, by basically saying, well, we are going to give added weight to the QPA, which is the median in-network rate. And so that's problematic because the median in-network rate is the median. And then if you're a health plan negotiating your new contracts with a provider, you know what the median in-network rate is, and you're not going to offer an in-network rate above that because that's the most you're going to have to pay out of network, most likely, unless the provider can win their IDR case. So that's one thing that is subject of lawsuits right now and also some lobbying. The other thing I would point out is on these patient protection pieces, for the patient's cost sharing, again, they're protected in that they're limited to, the provider is limited to only being able to bill the patient up to their in-network cost sharing amount. And there's no balance billing allowed above that. But they cannot just take their out-of-network charge and apply that to the patient's deductible. It has to be either the lesser of their out-of-network charge or this QPA, the median rate. Now that's, from a policy standpoint, okay, that's what it is. But from an operational standpoint, where the RCM companies really live and serve their clients, they need to know what that QPA amount is so that they can appropriately bill the patient. Well, the regulations that CMS put out say when specifically the health plan is supposed to communicate the QPA to the provider, and that is when they make an initial payment or denial. But it does not say anything about how the health plan is going to send the QPA amount. So it's not a standardized way. It could vary from payer to payer. It's just not clear. And then I've had the opportunity to ask some people at CMS about this, and they basically said that they didn't really think this through in enough detail to give an answer to that, and we're going to have to see how it goes. And perhaps there's some opportunity to make some improvements or to get some new regulations or guidance issued on how it should be done. So, I'll just kind of, put a pin in the patient protections there, and there's a whole lot to it. But there's this other second piece to the No Surprises Act, which is this good faith estimate requirement. And that really crept up on us because the No Surprises Act statute, it said that, you have to come up with a way to give patients who are uninsured or who are identified to the provider as self-pay. So they might have health insurance, but choose not to necessarily use it. They might think they can get a cheaper price, from provider directly. But that, there has to be a way to provide these patients with a good faith estimate of care. And then this second interim final rule that CMS issued which really outlined all the key details, went much further than anyone expected this to go. And this was issued in like October or November. So it was really caught a lot of people by surprise, and there was really not a whole lot of time to really, to really scramble to educate people and figure out what it meant. But basically, it's, if your patient identifies as self-pay or is uninsured, it's either upon request or when scheduling care. So scheduling staff is going to have to ask all these questions to figure out if this would apply. So it's, again, either upon request or when scheduling care, assuming the care can be scheduled at least 3 days out. So there are no emergency or urgent care services. The provider has to furnish these patients with a good faith estimate. And there's the regulations go into detail about, how the information is going to be included, and everything. There's a whole lot of details on that. But this difficult, challenging piece is that the good faith estimate also has to include care that's expected to be furnished in connection with that initial or primary service that the patient is going for. And that could involve other providers from a different location, different practice, a different facility, different system. And so it's going to involve a whole lot of coordination between the convening provider and perhaps others. And CMS recognizes it's going to be difficult, and they're actually delaying enforcement of that connected care piece. But they're going to put out more information about how they expect it to be implemented at some point this year. And then there's also this a third component to that, and it's the advanced EOB that the health plan is going to have to provide to the patient if they have insurance, that will list both the health plan's price and the good faith estimate. So the practice is going to have to furnish the good faith estimate to the patient's health plan as well. So there's a whole lot of differences based on if the patient's going to submit the bill to their health insurance or not. But it's going to, and that advanced EOB requirement also was delayed in enforcement this year because they have to figure out how to make that work. but it's this whole idea that, this more consumerism focus for patients as consumers, and how do you empower patients with price data and price transparency. So, that's kind of the purpose of this, so that the patient knows that maybe the health plan price is not the cheapest price, and maybe you can get a better deal directly from your provider. Maybe you'll shop around, things like that. And if you're uninsured, you have at least some protection, because the last thing I'll say on this is if the good faith estimate of the bill the patient receives exceeds the good faith estimate by more than $400, there is an arbitration process similar to that IDR process we just spoke about, that provides patients some recourse to get a lower amount. So it's a lot of, like I said at the beginning, details that we are aware of that are problematic, or some details that are very important that are just frankly missing.
Okay, so just a clarifying question on the advanced COB. Is this going to be required from all commercial payers, Medicare? Well, Medicare has their published fee schedule. So is this just for commercial payers?
Yeah, this is a commercial payer focused policy.
And so, and it's for all types of services. It could be inpatient detox, urgent care.
Yes.
All of it.
That's an important clarification point, because, and thanks for raising that. So when I started out talking about the patient protections against the out-of-network bills, I said, those apply to really hospital, emergency departments, and ambulatory surgical centers. The definitions, called facilities. But this good faith estimate requirement, it applies to essentially every healthcare provider in the country. Basically, anyone who's licensed by the state to be a healthcare provider. So it's very far reaching, and you might not be the convening provider. You might be this provider expected to provide a connected care. Maybe you're the imaging facility and you're getting referrals from all these providers who are going to have to furnish their patients with a good faith estimate. So it's a challenge. I think a lot of practices are going to have to really spend some time really thinking about what their most common services are, kind of have it ready, information ready to go, because they're such a tight turnaround time. I think they only have like a day to respond to these requests and everything. And again, as the convening provider, if you think the patient's going to need an x-ray, how do you know what x-ray facility they're going to go to? The one you refer them to is probably where you start, but if the patient chooses a different facility, there's all these requirements about updating the good faith estimate from this other facility, and it's going to be very challenging. And I CMS went a lot further than any of us really expected, at least, based on the more kind of high level, I guess, more vague statutory language that was in the original No Surprises Act. So and again, this came out at the end of the year, and the end of 2021. So it's just been a lot to get our heads around, a lot to figure out how to educate folks and how to really figure out how to comply with this.
Well, let me just ask about the good faith estimate. When do you expect that to go into effect or be enforced?
So that is in effect. The first part of it, that the patient has to get the good faith estimate for the primary service, that for which they're requesting the appointment. So if it's a sore ankle and they're going to a primary care for that, they think they sprained their ankle. So yeah, the good faith estimate only has to include the primary care provider's, expected care, or examination of this sore ankle. It doesn't have to necessarily include that x-ray that they might refer them to. You're allowed to if you want to, but they're not enforcing that piece.
Okay, so I guess it is in
effect.
Okay, but the advanced COB, which is coming from the insurance side, is that in effect?
No, that is the connected care piece and the advanced COB piece are not in effect, or essentially enforcement, discretion is being applied to, they won't enforce those provisions right now because they haven't, for the advanced COB, they haven't figured out any way to provide for how the provider is going to communicate this information to the health plan and things like that. So there's still a lot of work to do.
Well, you would think that there's so many portals, Availity and all these different portals, insurance portals, you should be able to just type in the CPT code, put in the patient's name, and get, the advanced COB. That's just like an eligibility checker, right? But I think it would,
Sure.
if it went through, it could really reduce a ton of denials, because insurance companies are denying claims saying this is not covered. Well, with an advanced COB, I don't know that they can make the same argument, right?
Right. And that, yes, it's hard because, yeah, I mean, you're getting pricing up for a service that hasn't occurred yet. It hasn't been submitted to the health plan yet, so it hasn't been, run through their edits and such. But, I think to your part you said about the different portals, I mean, yeah, that's the need to figure out is kind of what's the process for communicating this good faith estimate, which is supposed to be provided in a standardized way to the patient, to the health plan. And one thing that we advocate for HPMA is the importance of standardized electronic ways to do basically any sort of communication with a health plan, because those portals, they all have their own passwords. They're all different. It's just extra work. It's just extra time just figuring out how to use them all, managing passwords, managing users, things like that. Really what we want is, and something we'll be sharing with CMS as this process goes, continues as they figure out how to implement this, but that there has to be standardized way, ideally somehow based on, HIPAA transactions as much as possible. But it's, that's one thing that CMS did say when they explained their decision to not enforce the advanced COBs, that they are trying to figure out a way to do this in a standardized way to communicate this information.
I love this COB thing because I would like to believe that this would reduce a lot of the insurance denials. And that's what RCM companies primarily are busy with, is just dealing with insurance rejections. So if you can reduce the rejection rate by whatever percentage, it sounds like a great thing for the provider, and to reduce, hopefully, like it would result in that, but it seems like it's too early to tell.
Right. Well, hopefully it does include that information. So when the health plan kicks back their an advanced COB that includes the provider's good faith estimate, that they will say, well, this is actually not something we cover. So here's the provider's price is the price you'll pay. That's what it is. So hopefully patients will get that information, and maybe it will help patients because they'll know in advance. They'll have this information in advance as opposed to finding out at the end. And that's kind of the purpose of the No Surprises Act, is to help patients have, not be surprised, literally surprised by out-of-network bills that they didn't expect. And, you can get into the weeds on what a patient should or shouldn't expect, and things like that. And going to, the No Surprises Act really didn't apply to the typical physician office, because that's almost always care that can be scheduled in advance. So you have the time to, in theory, find that information out in advance, versus going to a hospital that you assume is in network to get a surgery and then finding out that the anesthesiologist was not in network. And here you are getting an out of network bill that you didn't expect. Or if it was an emergency service, you can't, pull the oxygen mask off and tell the ambulance to go to the other emergency room that's in network. They're just going to take you to where they take you. So those are times where the patients just don't have any real control over the process.
Right. Okay, speaking of reimbursements, let's give us an update on the physician fee schedule. Anything new there?
Sure. Yeah. So the physician fee schedule, I'll kind of lump this in with just kind of this general Medicare payments, because the end of 2021 saw a little bit of a dramatic fight here over certain Medicare cuts that were set to take in effect. And I'll use that word cuts, although not all of them are. They're all technically cuts. So one of them is, the Medicare sequestration, which we kind of all know about and have lived with for a long time. So 2% reduction to Medicare payments. And during the pandemic, Congress just kind of threw a bone to the healthcare industry and said, well, we're going to delay or pause the sequestration cuts and kind of reinstitute the full, get rid of those 2% cuts. But of course, they added some time on, a year or two on at the back end. So they extended sequestration by a few extra years, which is something that they've always done. But anyway, so they, starting this year, the sequestration cuts are phasing back in. So it's February now. So I think in March or April, I can't remember exactly which, it's going to phase back into a 1% cut. Then by July, back to the full 2%. Then again, adding some time in the back end. So, that was one thing that there was some fights over. The other is a set 4% reduction to Medicare payments that were triggered because of the American Rescue Plan legislation that was passed in the first few months of the Biden administration. in 2021, which it's because Congress, had passed a different legislation called PAYGO, which basically said any bill that substantially adds to, the federal deficit is going to trigger cuts elsewhere, so that you always have to pay for bills, basically. And Congress, as they can basically do anything they want, so they almost always just waive the PAYGO piece of any bill they pass adds to the deficit. And you say, well, this isn't going to count towards PAYGO. But for whatever reason, they didn't do that for the American Rescue Plan. So the 4% cuts got triggered. And, they could always have, they always had the opportunity to pass a different piece of legislation that just included the language to waive the PAYGO cuts for the American Rescue Plan. They can do that anytime they want, but they waited till the last minute, and they basically did it in a way that kicks the can down the road to next year. So those cuts are technically now set to take place in 2023. I don't expect it will ever go into effect, but it's going to be just an unnecessary political fight again, unless they really just deal with it. And then finally, and this is the fee schedule piece. We're all, I think, aware at this point of the changes to the evaluation management code set and the impact that those are having on payments across the board, how certain specialties are going to see, especially those that do a high number of E&M services, more cognitive focused specialties, going to probably see their payments go up as a result of those changes, while the more procedural focused specialties will probably see a decrease. And that's because Medicare payments are adjusted in a budget neutral way. So increases in one place are offset by decreases in another place. And so certain specialties were due to get a pretty sizable decrease the first year that those E&M changes took effect. So Congress passed legislation that for 2021, so this was back in 2020. So for 2021, that would apply a 3.75% across the board increase to the Medicare conversion factor for everybody. Whether you were a winner or a loser under the E&M changes, you got this 3.75%. And then, that was only intended to be a one-year thing. So coming up at the end of 2021, all the stakeholders in the provider community basically looked at this and said, in totality, we have Medicare sequestration at 2%, the PAYGO cuts at 4%, and then this 3.75%, expiration of that one time 3.75% cut. We basically added that all up to basically 9% or so, depending on how you look at it, because there's also some, it depends on your specialty, what the impact of the actual fee schedule changes would be on your specialties RVUs that year. So it's just, maybe 9% is not accurate for every specialty, but you really said, well, it's just too many cuts, and then MIPS and all these other things that are out there. So again, the sequestration is going to resume. They kick the can down the road on the 4%, and then rather than letting the 3.75% just expire after a year, they passed basically another year-long 3% across the board increase the conversion factor for this year, 2022. So these fights over the conversion factor spending are going to be kind of, at least in the hope, probably at least for the rest of the end of this year, they're going to come back again. Who knows if Congress will sort of deal with stuff on a more permanent basis. Medicare itself is kind of statutorily bound to do these changes in a budget neutral way, so they only have so much control over what they can do. So it's going to really come down to Congress again. So just something to keep your eye on. Again, probably not until the end of the year, but definitely something that's probably going to come up again.
Okay. It's a constant thing. It feels like it's going on forever. Let's touch on the value-based payments. That's a hot topic. What could you share about that?
Sure. So we're still in the transition, if you will, from fee-for-service towards value-based payments, although you can really say value-based payments are just a different way of doing fee-for-service, because the actual fee-for-service payment system still exists. They're just adding these quality and cost and other measures kind of on the back end that will adjust payments based on your performance in these different programs or models or whatnot. But this whole idea that there's got to be some way to hold providers accountable for the cost and quality of care they provide is really what we mean by this. And there's lots of ways they do it. There's the MIPS program, There are ACOs, there's the hospital readmissions reduction program, there's these episode payment models for specific conditions, like the joint replacement model, things like that. And I think what CMS is really realizing is that it's not really working for patients. Whenever you talk about these issues about healthcare spending or really any healthcare policy, it's important to keep in mind that there's three parties in play. There's the payer, the provider, and there's the patient. And in this case, we're talking about Medicare. It's the payer, and so these value-based payments were designed to help Medicare, the payer, control its spending. And of course, the goal was to also improve patient care and patient outcomes along the way. But I recently attended a webinar that CMMI, which is the office within CMS that does all these, creates and demonstrates all these new value-based payment models, where they said they need to do a whole strategy reset. And they're in the early stages of that because they're realizing that patients don't really have any understanding of what value-based payments are. A lot of patients barely understand what Medicare is, their benefits and their coverage there. And so they're saying, the patient doesn't know what an ACO is. They don't really understand, what these models are supposed to do for them. All they know is that they schedule care and they expect, to get what they schedule, the care they scheduled and stuff like that. And also there's a huge health equity component to this, where health equity has been a huge goal for this administration in a lot of what they do, but particularly within Medicare. The current administrator of Medicare, the Centers for Medicare and Medicaid Services, Chiquita Brooks-LaFleur, has basically said health equity is going to be a pillar, part of everything that they do, everything. And of course, you look at these value-based payment models, and you look at the way they're designed, and providers who treat a disproportionate number of patients who are medically or perhaps socially complex or at risk, whether that's, number of chronic conditions or perhaps, unstable social situations. If you're a safety net provider, let's say, you're treating a high number of those patients, you're going to be disadvantaged in these value-based payment models that hold you accountable for cost and quality compared to your peers who perhaps, don't treat as risky of a population. So, and then if you look at really these numbers in greater detail, and you look at, okay, which patients are most likely to have these chronic conditions, that can make them more medically complex. What we find is a lot of times it's minorities. And if you look at, or patients or people in rural America, whether they're, doesn't matter, so it's geographic, not just racial or ethnic. When you look at some of these social factors too, that we know, are good predictors or indicators of health. And same thing, you see that a lot of, racial and ethnic minorities and geographic minorities and rural patients are more impacted by these factors. So these are the patients who are going to, be harder to achieve a positive outcome for under these models. And so these models need to be designed in a way that essentially adjusts for these complexities, whether it's medical or social, and recognizing that it impacts certain populations in different ways. And I think that there's kind of a much more growing, I guess, acknowledgement of that and a more of a stronger commitment to do something about that. So again, we're at this early stages, but I think, we're going to see a continuation of these value-based payment transitions. MIPS isn't going anywhere, things like that. But I think we're going to start seeing CMS look at these programs in different ways, in ways that prioritize equity, that perhaps prioritize, again, what patients view as quality or what they view as, value. Because survey after survey and research after research ask patients and providers and health plans, kind of what they all value in healthcare. And then there's a whole lot of, it's just complete, lack of alignment where all three are saying different things. And the patient, what they want above anything else is clear communication and respect and things like that, and that's not what's being measured by these quality measures. I mean, I don't know how you measure, respect or clear communication or things like that, but we know there's a disconnect, and we don't necessarily know the answers for how to redesign these models in a better way. But it seems like we're moving towards a recognition that they need to be redesigned in a better way. And so I think just keep an eye on that. We're in the early stages of it. There's plenty of time left to figure it out, but I think that's just something to keep an eye on over the course of the next year, maybe several years.
Very interesting. You get these surveys from doctors after you finish, how would you rate your visit? You get a text message. I wonder if they'll, go to that way and really let the patient truly decide. Do you see value-based payments on the commercial side, or is it just going to stay on the Medicare side?
It's certainly going to be driven by the Medicare side. I think, commercial payers, they do it, but, Medicare takes the lead. They always follow Medicare's lead. And of course, look, value-based payments are essentially a way for payers to justify reducing payments to providers. Well, if you didn't score well enough, then, that's why we're cutting your payments. Now, that's maybe the more cynical view of it. There's obviously these, if designed correctly, they hold providers accountable for cost and quality in a real sense. And that way we're having more efficient and better care outcomes. And those are both good things. They're things that everybody wants. But, I think if you really look at and pull back and look at this whole idea of value-based payments, it's not really doing anything about the actual price or the actual cost of care. It's basically just changing payments. It's changing payments regardless of what the cost is. It doesn't, or what it actually costs to deliver care to these patients. And there's, a whole lot of now also attention from this administration and the previous administration too, to try to put the prices out more in the open so that we can see that a hospital on one side of the city charging twice as much as the hospital on the other side of the city for the same thing. Why is that? And, how do you kind of create some sort of parity, or at least some more, get rid of this huge price disparities, within a market or across different markets. And because again, it's all markets, it's all negotiations, we know that, but, it's all part of that, this idea of what is the cost of care. And that's something that's going to go a little bit further than tweaks to value-based payments, this kind of push for price transparency, which is going to, again, look more at the actual cost of care, while these value-based payments are going to look at kind of how we pay for healthcare and what incentives might be included within those payments.
Very interesting. Okay, very helpful. Okay, as we wrap this up, why don't you update us on what's going on with telehealth? Because it was approved, and everyone wants to know, how long is this going to go on for? And is this something that we could expect to happen, to have an effect indefinitely, just because it seems to be working so well? Where do you see this going?
Yeah, I think so. In particular with Medicare telehealth, start there because, the commercial payers are well ahead of Medicare in terms of telehealth coverage policies. But even though we're seeing a lot of these pandemic focused, coverage flexibilities and expansions, even by commercial payers, kind of rolled back a little bit. But Medicare in particular, they're bound by statute. They're bound by Congress as to what they can or cannot cover for Medicare telehealth. And during the COVID-19 public health emergency, which was just extended again for another 90 days, just a few weeks ago, because they're extended 90-day increments, basically gives us a little bit more time with these Medicare coverage flexibilities, which were passed as temporary policies during the pandemic, and they are set to expire when the public health emergency expires, although they said, and Congress has said that actually that these policies will remain in effect for the duration of the calendar year that the public health emergency ends. So it's not going to be just a sharp decline. It's going to be, we'll have some leeway to know. But Congress knows that we can't go back to the way things were with Medicare coverage, or telehealth coverage, which basically.
Wait, you just cut out.
Okay, my Bluetooth headphones cut out there. I'll back up there. So we can't go back to the way that Medicare covers telehealth. Congress knows that. Basically, Medicare coverage policy, telehealth coverage policies pre-pandemic requires the patient. Well, first of all, it's only limited to patients in rural areas. Second, it requires those patients to travel to an originating site, or doctor's office or rural health clinic or somewhere, and then connect to the distant site, specialist somewhere else, and has to be done via this HIPAA secure connection. And there's a whole list of codes that can and cannot be covered, things like that. And during the pandemic, we've seen all that go away. The patient can be wherever they want. they can basically use anything that isn't any communication medium that's not, public facing. So not like Facebook Live, but like Zoom is okay or FaceTime's okay. There's you can't, again, no originating site or distant site. And, Congress is not going to let it go back to the way it was. I think there's going to be some things that remain in place. They might still say, okay, it has to be done via HIPAA secure, communication medium, but they might say the originating site, distant site stuff is going to go away. Patient can do this from wherever they want. So Congress is just now, again, we're sitting here in February. I wouldn't be surprised if in the next few weeks they pass legislation that proactively extends some of these telehealth provisions on a permanent basis. I think it's something that everyone wants to do. They just they're still just kind of figuring out exactly how and what they want to extend on a permanent basis.
Wonderful. Is there any kind of uniformity between the commercial payers when it comes to telehealth? Because I know they're all just a little bit different. Is there any talk about making it more streamlined? I mean, you're saying across commercial payers in particular? Mm-hmm. Not that I'm aware of. I think that's going to be something to look at individual state laws. They might, try to pass, payment parity regulations or certain coverage policies that would apply more universally to all plans in their states. Again, most commercial health plans are regulated by states, not by the federal government. I think one just kind of frontier to keep an eye on too is this idea of, I don't call this telehealth, I call it digital health. When you think of telehealth, you think of this two-way connection between a patient and a provider over video. But digital health includes so much more. It's remote patient monitoring, things like that. It's going to be interesting to see how those new kind of treatment models and care models are created and how they're reimbursed and things like that. Because I really see that as a bit of the future where it's not just this kind of reactionary come in when you're sick, come in for your follow-up visit, but there's real-time monitoring of patients and there's real-time ability to know what's happening and to intervene when necessary so that, you can notice that the patient's blood pressure is spiking, in real time rather than saying, oh, we'll schedule an appointment, come in next week. And next thing you know, in that intervening time, they end up in the emergency room. So, I think that's, again, that I wouldn't call it telehealth. I'd call it digital health. And I think that's something that is really, in a lot of ways, kind of the next frontier when it comes to care delivery and reimbursement and such. Yes, absolutely. I like that you're calling it digital health because I think that's a lot more accurate. Absolutely. Matt, thank you so much. This was so wonderful. And we crammed so much into these like 30 or 40 minutes. So thank you for prepping with me and really delivering such great quality in such a limited time. So I feel like I don't need to read every single publication that comes out. I could just talk to you for 40 minutes and get the whole lowdown. So I really do appreciate it. Where can people find you? Tell us your website so that we can, and what's the best way to stay informed? If I'm, in the billing business, what would you suggest are the sites or the people I should follow?
Of course. Well, I can say, of course, being a member of HBMA provides you with great access to this information. HBMA is one of the organizations I work for. I actually serve as their Associate Director of Government Affairs, and we provide monthly Washington reports on all of these topics for them. We do webinars, we speak at conferences and such. So HBMA just has a lot of resources on these topics that we put together. Some things we do put together on our website, which is capitalassociates.com. But most of what we do is, again, we provide for our clients and they will put that out to their members. So, those are really the two best ways, I'd say, certainly our website, but if, again, most of what I'm putting out that's RCM focused is going to be put out through HBMA and it's put out in a variety of different ways.
That's wonderful. Again, thank you, Matt, so much. And I look forward to talking to you again soon.
Of course. Well, thanks so much.